Good afternoon, Dr. Costanza.
Good afternoon, Umar.
To start off, could you tell me where you went to medical school?
University of Rochester, Rochester, New York,
When did you graduate?
1968.
And when did you start practicing?
1972.
What was your specialty?
Well, I specialize in medical oncology.
What made you choose medical oncology?
Probably two things. One is it's a new field at the time, so it was a very great challenge. Not much was known about cancer. And secondly, I like the fact that it wasn't focused just on one organ, like the heart or the kidney.
Right. Could you describe a typical day when you first started practicing?
Okay. I've been in academic medicine the whole time, so it's a little bit different than people who are out in community practice. So a typical day might be I'd come in in the morning, perhaps 9 o'clock or so. Usually the first thing on the agenda was to meet up with the house staff and the inpatient service. So to go over those patients, and then usually there'd be an hour or so of teaching the house staff. And then in the afternoon would be clinic, and at some point trying to do research and scholarly activities. Mostly those were just crammed in around the clinical issues.
Right. How did your typical day of practicing change over the years?
It really hasn't changed a whole lot until recently. I've given up doing inpatient practice, so mostly I'm doing research and outpatient work now. But other than that, the general format was the same.
And what were your hours like?
Well, once I got through with my training, the hours were reasonably stable, which is one of the benefits of having an academic practice, and that is you can make it, 8:30 to 6 or 9 to 5, or have a fair amount of control over your hours because you are in a group practice and you're covered by house staff and so forth.
When did you go to the hospital to work?
You mean in the morning or during the day?
How often?
Well, here and also where I was before at Tufts, basically my office was in the hospital, so I was there all the time.
And what were your rounds like?
Well, rounds again were focused on helping the patients who were admitted to the hospital, and then teaching the house staff who were involved in caring for those folks. So probably you would spend an hour or two, depending on how many patients there were, going over the patient problems, and then maybe a half an hour to an hour teaching about issues that came up because of those patients.
Who were your patients?
Well, they're principally, since I got into practice, all medical oncology patients.
Okay. And most of them lived around the Worcester area?
The ones, Worcester, I would say that a fair proportion live within Worcester or the immediate surrounding countryside, right?
Did patients get to choose their physician?
A lot of patients are referred. Cancer patients are usually referred to a medical oncologist. So they might be referred to our group, and they might get me because I was the next person to accept a new patient. Or often they would be referred to me directly, so they would come to me because some other physician had told them. Or sometimes they come because they've talked to a friend or a family member and they've recommended me. So that's basically how they come.
What do you think it was like for your family to have a physician in the household?
Well, I think they liked the idea of having a doctor in the household. Feels good. What about you? The same?
Yes.
It's kind of nice.
But, I mean, she's always tied up being a doctor. So.
Right. Again, I think I've been blessed in the academic practice because you can control your hours a lot better than if you're in general practice. My dad was in general practice, and his life was not his own.
So what made you decide to become a
I wanted to do something, you know, worthwhile or important with my life.
Okay.
And my dad was a doctor, so my uncle was a doctor too, so they were role models for
I
me.
see. And what made you decide to keep being a doctor?
I like what I do. I like my patients, and it's very challenging. It's a privilege.
Why did you practice in Worcester?
Well, I got a job offer I couldn't refuse.
Do you have a favorite memory from when you practiced?
Oh, let's see. There was a young man when I first started practicing who had Hodgkin's disease. He didn't want to be treated. He was very resistant. We had to basically walk him through every little thing, beg him to take the therapy. It was a long struggle, but he finished it. And then a few years later, he moved from Boston, which was where I was at the time, and I got a postcard from him. He was married on the rim of the Grand Canyon, and I thought that was just great.
That's nice. Do you have a least favorite memory?
Well, yes, I had another patient with Hodgkin's disease also during my early years, a young girl, not even 20, who died of the disease, and that was very painful.
What were the most typical diseases that you dealt with when you practiced?
Breast cancer, colon cancer, lung cancer.
Okay. And in subsequent decades,
Same thing.
what was the greatest challenge for you to treat?
Well, probably as a medical oncologist, the hardest thing to deal with is the fact that you're dealing with a lot of patients who don't get better, who die, and it's hard to learn how to deal with that so that you can still be a good doctor and still be caring about them.
And that probably hasn't changed.
That hasn't changed, no, it's still hard.
What was one of the most important breakthroughs in disease treatment, in your opinion?
Well, in cancer, almost everything was in terms of medicines. Let's say in the 50s and 60s, we had very, very few, maybe 1 or 2 chemotherapy agents, and now we have hundreds, and we have new kinds of agents. We have monoclonal antibodies and interferon and all kinds of things that we did not have before. So that's been very exciting.
How about in technology?
Well, when I started out in medical school, they used to show us slices through the human body, and I never bothered to study that because I couldn't imagine why I would ever see people sliced in pieces. And of course, very shortly after that, the CAT scans were developed. And those were correlated actually with all those slices through the human body. So that was one of the big new advances in technology. And now, of course, we have MRI and PET scans and all kinds of stuff that we didn't have then.
What was the worst epidemic that you can recall?
Well, I was in college in the 50s. There was a terrible epidemic of polio in Boston. It was awful.
All right, before we move on, could you just quickly describe attitudes towards smoking and cancer through your career?
Well, let's see. First, I'll confess that I used to smoke myself many years ago, as many people did. Half of the population smoked. It was thought to be very sophisticated and, attractive and worldly. And then, once you start smoking, there's a tendency to, as you know, to get hooked on nicotine, and it becomes harder and harder to stop. So after I stopped, I think I probably didn't think about it a whole lot. And I considered smoking to be something that the individual person did, and, for their health it would be a nice idea if they stopped. But gradually I've come to see that that's not really the whole story. The story really is the tobacco industry. And the tobacco industry is not somebody who just happens to provide somebody a cigarette. It's an industry that really does everything it can to addict people in a very aggressive fashion. So I really come to see them as kind of the evil empire. They are the evil empire, there's no question about it. And I really see people who are continuing to smoke now that we have so much advocacy about not smoking. People who are smoking now are in trouble. They can't stop because anybody who has any sense would stop smoking. If they could, do it easily. So that's one issue. And the other one, of course, is that we continue to have all these young people start smoking. And that's not an accident either. Those people are targeted by the tobacco industry.
I agree. What is something that doctors take for granted now that you didn't have at some point in your career?
Gosh, there's so much.
Yeah.
So much. When I was an intern, we didn't even have people that came and drew blood. We had to go and do that ourselves. And at nighttime, if you wanted to get electrolytes drawn or something like that, you had to call a technician in to do it, and they'd always give you a big argument. What else? Oh, if we did urine analysis, we had to do that ourselves, or plate all the infectious disease things. So obviously it's come a very long way from it's kind of a primitive time.
What technology is still being used that was in use when you were in medical school?
Well, mammograms were being used then. They're much better now than they were technically. They're much better able to discriminate tiny calcium and small tumors and so forth. CAT scans started probably in the early 70s, and they're still being used today. Again, they're much refined, but those were technologies that were there then.
Okay. Can you describe one important invention that you've seen during the course of your practice?
Well, the MRI is probably an important, certainly it is an important one for medical oncology, neuro-oncology. That's been a very, very good thing. The PET scan is another one that's not in wide use, but still can be useful in specific cases.
What would you like to see invented?
Oh gosh, a really great drug that would cure cancer.
What were some of the most important drugs that you used in your practice?
Well, some of the old ones were Cytoxan, 5-fluorouracil, methotrexate. Those were around, you know, in 1968 when I started as an intern, and they're still around, and they're still pretty standard for many things.
Are they? Yeah. Did you always have access to the drugs you wanted to use?
Pretty much.
Okay, good. What breakthroughs in drugs have you seen, and when did they occur?
Well, the breakthroughs for medical oncology, they started out probably again in the 70s with adriamycin, which was a very important drug. Comes from a Streptomyces organism that was found beside the Adriatic Sea. That's why it was called adriamycin. And then subsequently we've had the taxanes, which were derived from the western yew tree, from the needles of the tree, and then became semi-synthetic. And then most recently, in the last 10 years, we've had the monoclonal antibodies that have been focused on specific proteins in the body. And now there are some newer developments that are looking at gene mutations and trying, like P53, trying to correct those problems. And those are just astonishing. And then there's so many of them now. So it's great.
And how did the changes in drugs in the drug industry affect your practice?
Well, we had to learn a lot about all these drugs and how to use them, and many of them are used, there are different ways to use them. Some are given, you know, by a quick injection, some have to be given over an hour, some have to be given, you know, every day, all day long for a week. So there are different things that you have to learn about them. Their toxicities are all different. Some of the combinations are not good. There's too much toxicity with some combinations, so you have to learn about that.
All right, moving on to a different topic now. How did patients without money get health care?
How do they get help? Well, currently, always, people got free care to a certain extent. And I think, again, I was at Tufts in Boston and here at UMass in Worcester. If people came to the door and they didn't have money, they got care somehow. That's not always true in a private practice setting. People don't have the luxury sometimes to provide a lot of free care, whereas the hospital can do that. And then, of course, the whole Medicaid system for people who didn't otherwise have insurance.
Do you think everyone who needed care got it?
I think got emergency care. If they needed emergency care, they got it. I think if they needed sort of preventive care and kind of counseling about things, let's say somebody comes to the emergency room, they're not going to get told about having mammograms or having a colon cancer test or have counseling about stopping smoking or something. They're going to get the basics, you know. They're going to get sewed up, or if they have a heart attack, they'll get, you know, that address. So without a good insurance plan, you're not going to get kind of, I think, just good basic medical care.
Over the years, how do you think Worcester compares to other places in terms of providing care for the underserved?
I think actually it's got a very active program, and I think very impressive. And I'm very impressed by the number of people who are involved and try to provide care, both in the clinic, you know, like Great Brook Valley and down at Worcester City and so forth.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Well, there were a lot of concerns. I mean, it was practically a communist takeover, and people really went beyond themselves on this one. So there was a tremendous amount, and the American Medical Association took a very vocal stand against anything that smacked of socialized medicine. And I think actually I can't remember whether they were against Blue Cross, Blue Shield or not. Actually, Blue Shield was started to help pay doctors. But there was a lot of discussion about it. That sort of antedated my time in medicine, so I'm not very clear on that.
Were physicians involved politically on this topic?
Well, certainly through the AMA, like the Mass Medical Society, yes, there was a lot of discussion about it, kind of a furor about what was happening to medicine.
What were your feelings on Medicare and Medicaid when they...
Well, when I came along in medicine, they were already in place, so I really, you know, they were there for me to look at. But as I saw them, they were mechanisms for payment that helped people who may not have been able to pay for medical care get care. And once Medicare came in, I mean, once you had Medicare, then you were able to go and find a doctor of your choice. So that was one of the big things that happened when older people finally got that insurance help.
Have your feelings changed at all over the years?
About Medicare?
Yes.
Well, Medicare's been a great boon for older people. I mean, if you look at, say, the free clinics around town or in the big cities, they're mostly filled with younger people, mothers and children, because there are a lot of needs at that time of their life. And older people used to go to those clinics, by and large, don't have to go there anymore. They can have a private doctor because they have Medicare. There's now some constraints on that because there are now physicians who won't accept Medicare. And the reasons are financial, because Medicare is not reimbursing at a rate that physicians think is high enough.
Okay.
And that's a problem. because I mean, I'm not trying to say that physicians should get rich off of Medicare, but if Medicare is not reimbursing at a rate that actually allows you to make at least a small profit on whatever it is you're doing, then physicians aren't going to do it anymore. For example, until recently, mammograms for Medicare were reimbursed at $50, and $50 does not cover the cost of the film, the machine, you know, all the things, the person who reads the film, the technician who helps set it up. And so physicians were basically losing money on that.
That's too bad. Do you think the government has become more or less involved in healthcare?
Well, to the extent that the government is involved in the Medicare program and also in the Medicaid program, I suppose it's more than it was at the time when they didn't have those programs. But in another way, they are involved less. If you compare us, say, to any other industrialized country in the world, government is not very involved in medical care. It really doesn't set standards very well. And it certainly, you know, doesn't provide for health care directly for the vast majority of the population. That's done through private insurance.
And how has this affected physicians?
Well, physicians are kind of caught in the middle because, on the one hand, they have to deal with all the HMO, MCO organizations, and they're certainly getting squeezed there. And secondly, they're being, on the other hand, being squeezed by the government that's not reimbursing them at a rate that is compatible with, you know, making it. So they're stuck.
And of course, the patients have been negatively affected.
They have been negatively affected, and I mean, many people blame physicians themselves for not being advocates enough, and I think to some extent that's true. We haven't been. We've been busy taking care of patients, and we haven't really advocated for ourselves strongly enough, or for the medical system.
What do you want to see happen with government and healthcare?
Well, in my way of thinking, again, we're the only industrialized country in the world that does not have a national health system. And I think we absolutely must have a national health system. What exactly it needs to look like, I'm not an expert, I don't know. But I certainly would think that we need a basic health program that's not necessarily based on being employed. It's just based on living, breathing. And then maybe you could have a fancy program that was funded by private insurance for people who had lots of money who wanted to have fancy things done, but that everyone would get a very good basic plan to take care of their basic needs.
Yeah. When did HMOs first start to impact your practice?
Probably within the last decade.
Okay. And what was their impact?
Well, they are a royal pain because they've got all these rules. Every HMO has a different regulation and rule. For example, if you have pneumonia and I prescribe an antibiotic for you, the chances are that I'll get a call from the pharmacy saying, well, you know, this health plan doesn't cover the antibiotic that you wrote, but it does cover some other one. And so pretty soon you have all these people sort of interfering with the practice of medicine. The HMO's telling you which antibiotics you can use, and there's just more and more of your day that is spent dealing with these kind of administrative issues rather than really dealing with the medical issue of trying to treat the person appropriately, you know.
Did you ever have any involvement with these HMOs?
Yes, I've had some very unpleasant phone calls with HMOs trying to get them to cover something that I think a patient would need, and then finding myself talking to somebody who's very well trained, very ignorant, but very well trained, who won't give in, basically.
Okay. Are there any positive aspects of HMOs?
Well, I think, yes, to some extent, a lot of people, at least initially, were able to get what they thought was reasonably cheap insurance. And unfortunately, some people choose the cheapest and then realize only too late that it doesn't really cover what they need. And a lot of the HMOs promised, I mean, their whole idea was health maintenance. That was their name, health maintenance. And actually, if you look at their record in terms of, let's say, preventive services, did they really push screening mammograms, checking for cholesterol, getting people to live healthy lifestyles? The answer is no, they didn't do a very good job. And they mostly have been forced into it through government regulation.
Of course, we've talked about the negative aspects already.
Right.
Anything else to add?
Well, I mean, a lot of people got angry at the HMOs because they wanted to be cost effective, and that was a battle cry for a lot of doctors for a long time. But there's nothing wrong with cost effective, and I think, you know, being cost effective is a good thing to be. There's no need to be wasting money over things that don't work, or even choosing expensive medications when less expensive ones work just as well. But the whole layer of bureaucracy and administration is just too cumbersome. And partly it's so cumbersome because you have so many HMOs and each of them have their own regulations, and you know, this could be avoided by a national program, one program.
Yeah. All right, I'm going to move on to the finances of medicine now.
Oh, finances, okay.
How much did it cost for you to go to medical school?
Do you know, I have no idea. My father paid the bill, he insisted, so I gave in. I'm sure it was not anywhere near as much as it is today.
So the cost of school didn't influence where or how you practiced medicine at first?
No, I didn't have it. When I graduated from medical school, I did not have a debt, so I was a very lucky person not to have a debt to work with.
Do you think school costs today influence the
Yes,
choices?
yes, very much so. I think we see it here at UMass. I mean, people are knocking themselves out to get here because of the price issue.
Yeah. How have doctors' salaries changed over the course of your practice?
Slowly. I don't, you know, again, I'm in academic practice, so academic practice is always a lesser amount of remuneration than, say, somebody in private practice. If you want to get rich, you don't go into academic medicine.
Where did most of your income come from in the early part of your career?
Well, again, that's hard. It's not really a good question for me because as an academic, I'm salaried.
Yeah, okay.
And now, however, there is a movement on for people to account for themselves in a very kind of mechanistic way. So you're looking at how many patients you see and how much you bill for each patient and how much you collect and so forth. It's not, I mean, it's not wrong to be mindful of these things, but most of us went into medicine not to go into a business. We went into medicine to do something else, and the business part is second. So having the business part become first is very upsetting for many people. It's certainly upsetting for me.
How has malpractice insurance changed over the years?
Well, the premiums have gone up and up and up. And the reason they've gone up and up and up is because the suing of doctors has become, you know, a national pastime. It's very lucrative for lawyers. There have been discussions about limiting the percent that lawyers take a percent of what they make on these cases. And I believe in Canada, there's like a set fee. So you only get, I don't know, let's say $5,000, no matter what the settlement is. And that has slowed down all of this malpractice stuff that was going on in Canada, because lawyers just aren't going to make that much money with this endeavor. And there are a lot of very frivolous suits that are harmful to people too. And then a lot of judgments that are, in my way of thinking, crazy, but and people have suggested that we ought to have a more rational view, so that you basically would put a limit on one life is worth so much, loss of one leg so much, an eye so much, and that would stop this escalation business too.
What were your typical fees for an office visit when you began?
You know, I really don't know.
And how did you learn the business of medicine?
Well, mostly I avoided learning the business of medicine because I didn't have to. Being salaried, I basically, and I think for many of us in academic medicine, we went into academic medicine in a sense to avoid the business end of it. We didn't send bills. Somebody else sent the bill for us. We didn't collect bills. If they weren't paid, somebody else did that. And you have no knowledge of what, they were doing. And then as time has gone on, we obviously can't continue in that frame of mind. We have to learn something about the business. And now we learn the business from the business managers in the hospital and the department chiefs and so forth. They tell us how to make more money and how to bill better, how to do this and that to improve our income. And most of us don't like it a whole lot.
Within the Worcester community, what are some changes that you've seen in the demographics?
Let's see, I guess, well, it's hard to say at Worcester itself, but certainly in terms of the patients that I've seen, I would say that there are a lot more ethnic minorities than there were when I first came in about 79. And probably the largest ethnic group is Hispanic, and then there are the various subgroups of Hispanics from different Central America and South America and so forth. And that's probably the biggest change in that aspect. I think I'm seeing more patients now who either come for free care or who come with Medicaid or also Medicare. And part of that is because they're maybe not so welcome to go other places, and they come to the University Hospital.
Right. How did women's health in Worcester change over the course of your practice?
Well, when we started out, oncology was still a fairly young field, so there really wasn't much going on in GYN oncology. And that has become a field of its own. So that's certainly something that's happened. And there's now more interest in women's health as let's say there's a new course now given for the medical students about women's health and gender issues, which never was in the curriculum before. So that's good.
How about treating like breast cancer? Like, how's that changed? When did that first arise in your career?
Breast cancer? Well, I've been doing that again since probably 68, but and it's just developed and become more mature as a field. There's been a gradual increase in incidence of breast cancer until very recently, when it seems to have peaked. But it was rising at one point 2 or 3% a year, so more and more cases were turning up. And that's changed over the years because there's been a shift from people presenting with late-stage cancer to people now, the majority of people present with early-stage cancer, small cancers, negative lymph nodes, and that's because screening mammography has become so widespread. So the tumors being picked up at a much earlier stage, they're much more likely to be cured than they were, say, 20 years ago, when mammography was fairly uncommon and people walked in with large tumors that they weren't going to do very well with. So that's a good improvement.
Have there been changes in how children are cared for at all?
That I have very little knowledge of.
Never worked with children at all in your field?
No, I haven't.
Okay. How has Worcester been different from other places you've practiced? Have you practiced anywhere else?
Well, the only other place I practiced was at Tufts in Boston. So Tufts is, you know, in a large urban center in the middle of town. It's in the middle of Chinatown. So a lot of the patients were Chinese, obviously. And they had a fair amount of referral in from the suburb. They had a kind of a network of hospitals that referred into them. They had an outpost in Maine that would send a lot of patients down. Worcester, you know, is a small urban town, and a lot of rural people who come in as patients. So it's a kind of a slightly different flavor to it.
What were public perceptions of doctors when you started practicing?
Well, doctors were held at a much higher level than they're held now. And I think people they were more in awe of doctors, more respectful certainly than they are today. And doctors probably had a much bigger idea of themselves than they have today, too.
How do you feel the role of the physician in the Worcester community has changed?
That's a hard one for me, I guess. Partly because I'm not that integrated into the Worcester community. I'm mostly integrated into the hospital, so I'm not that really knowledgeable about outside of the walls here.
Okay.
But I think in general doctors have become more kind of less monolithic. In other words, in the old days, doctors were just doctors. That's all they did, morning, noon, and night. And these days, I think people want a life. They want a family life. A lot of people want to be involved in the community. A lot of people go to the schools and talk about smoking or general health stuff that maybe they didn't do so much of in the old days. They didn't have time to do.
Are there Worcester physicians that you admired when you started out practicing? Or wherever you practiced in?
Oh, sure, right. I mean, they were sort of the old school, larger-than-life people, wonderful people. The giants of medicine. Part of it is when you're young, I think you have a view of older people as bigger and better in life, you know. Then you get to be one of those people yourself, and everybody looks a little more normal in size.
How about now?
There are still a lot of people I admire. I admire a lot of these young folks that are out doing work with AIDS people and homeless folks. I think that's a really tough area to work with, and I admire them for doing that.
What was it like for female physicians in Worcester in the 50s and 60s?
Well, I wasn't here in the 50s and 60s, but I was a physician in the 60s in medical school, and it was rough, very rough. People thought you were a complete oddball. It was just, I mean, it's hard to understand now how bizarre it seemed that a woman would want to go into medicine, or for that matter, anything. I mean, when I graduated from college, the options were nursing, teaching school, being a housewife or a secretary. That was it. That was it.
And in your opinion, how do you think that's changed?
Well, now you can do anything, right?
Yes.
It's changed a lot. There's still issues. I mean, certainly my colleagues and younger people are very open about having women do everything, and that's wonderful. There's still issues about power. If you look, let's say, at the structure of the medical school, you will very quickly see that the power structure is almost entirely male. And that has not changed, although people like myself and others struggle against it. And eventually it will change, but it's very, very slow.
What do you you like best about practicing in Worcester?
I like the people. They're very nice. They're kind of low-key, not as, I mean, if you think about New York or Boston, there's a lot quicker pace and competitiveness and stuff that I don't think you see in Worcester.
Yeah. And the least.
It doesn't have a downtown. It doesn't have a center city. It's hard to, like, love center of Worcester. There isn't any.
Yeah. Well, do you have any other stories or anecdotes?
Well, that's probably good enough for now. It's been a, you know, a lot of different things that have happened in medicine, and we're at a crossroads right now. Medicine's in trouble, and the people who are trying to get medical care are in trouble. Basically, you know, something's got to happen soon, and I can't imagine what will happen until we get enough patients who are angry enough to make their legislators really think about why we have the system that we have and why we don't have a better system.
And how about the field of oncology? I mean, do you have any comments?
So the field of oncology is really, it's hot. It's really hot. We have so many wonderful new drugs and new insights. For a long time, we were working in the dark, and now, you know, we know so much about basic biology and molecular issues, the whole, you know, DNA structure, all those kinds of things. We're just going to have a wonderful next 25 years. Maybe not with me, but the field is going to have a great another 25 years.
Good. Do you have any other experiences, maybe from medical school or throughout your practice, that you'd like to share?
Oh, I don't know. Too many to note.
We have time if you have any.
No, that's okay.
Okay. And do you have any advice for younger doctors?
Well, let's see. Medicine is a wonderful career. There aren't many careers, I think, that have so much range to them. There are so many different things that you can do within the field of medicine that it would be hard not to find a place or something that you would really fit you as a person, your personality, your ability to learn and so forth. And it's really a privilege to be able to take care of people. So they should look on the brighter side of things, even though these times are really, really tough. And it's really tough in Massachusetts, I think. Tougher here than a lot of states. We have so much of the HMOs and so forth. It's made it very difficult for doctors, and many of them are leaving. But I would hope the young people would hang in there and maybe learn to be stronger advocates than we were about the healthcare system, more vocal.
Well, I guess that brings us to the end of our interview, Dr. Costanza. It's been a pleasure, and on behalf of the Worcester District Medical Society, I'd like to thank you for your time.
Thank you, Umar. Thanks for asking me.
All right.